Assalamualaikum. I am Dr. Sayyid Mohammad Salim, and today I will discuss about metastatic bladder cancer. The 10 to 15% of patients are metastatic at the time of bladder cancer when they are diagnosed, and 50% of patients relapse after curative radical cystectomy. Among that, 30% is local relapse and 70% is at distant sites. A significant proportion of patients progress to metastasis because of delay in the definitive treatment. Survival outcomes. There is poor survival in metastatic bladder cancer, with median survival rate of 14 months with treatment, and 5-year survival rate is 5 to 20%. And quality of life is poor due to difficulty in timely diagnosis, lower urinary tract symptoms, and morbid treatment options. The delay in diagnosis is sometimes because of incomplete resections, understaging, impaired renal functions, comorbids, and upper tract obstruction, and delay in decision making. Usually these patients present with pain, suprapubic pain, retention, hematuria, and usually with weight loss, anorexia, fever, shortness of breath, and bone pains. These patients are diagnosed on cystoscopic biopsy and CT scan. Commonly, the metastasis goes to the regional lymph node, which is most common, and then lung, liver, bones, adrenals, intestine, and peritoneum. As metastatic bladder cancer cannot be cured completely, so these following factors help to decide the treatment options. That is performance status, local symptoms like pain, hematuria, retention, and upper tract obstruction, renal functions, and patient's expectation, that what patient wants. Now comes toward the chemotherapy of the patient. There are two regimes in first-line chemotherapy in metastatic bladder cancer. One is MVAC, and second one is gemcitabine cisplatin. In MVAC, methotrexate, vinblastine, erythromycin, and cisplatin is administered. The median survival is 14.8 months, and response rate is 46%. The main issue in this regime is it has a bit higher toxicity than gemcitabine and cisplatin, and time to progression is 7.4 months. This regime is well tolerated with GCSF, and GCSF is administered with the HD-MVAC. It is higher in efficacy, it is better tolerated, the response rate is high, and survival is 24 months. And this gemcitabine cisplatin it has a lower toxicity. The response rate is 49%, and it is becoming a new standard of care in metastatic bladder cancers.
So, this drug cisplatin, you must have heard a lot about it. Can someone tell how this drug acts, cisplatin? Dr. Noman?
It is anti-neoplastic agent. It enters into the cell by a particular receptor and acts on the DNA and produces the DNA defects. and these cancer cells, they don't have the excision and repair mechanism of that particular DNA effect which the normal body cells have. So this kills the internal DNA matter so that it cannot produce further tumorous cells again. The mitotic activity stops.
So what are the other drugs in this class, platinum based?
Cisplatin, carboplatin, oxyplatin.
Oxyplatin, okay. In which other cancers in urology this drug is used, Dr. Larip? Cisplatin. In testicular cancer. Even in bladder cancer, in another setting, it is also used. In bladder cancer, it is gold standard for in which setting? One is metastasis, the other is metastatic के अलावा भी यूज होती है ना ब्लैडर कैंसर के अंदर. डॉक्टर उमैर, ब्लैडर कैंसर में सिस्प्लैटिन यूज होती है. डॉक्टर मजर, सिस्प्लैटिन न्यू एडजुवेंट में यूज़ होती है. न्यू एडजुवेंट में बेबी फॉर रेडिकल सिस्टेक्टमी आप यूज़ करते हैं इसको. ठीक है, तो ये काफ़ी इंपॉर्टेंट ड्रग है, इसके बारे में आपको पता होना चाहिए. इसके कॉमन साइड इफ़ेक्ट क्या होते हैं, कॉमन प्रॉब्लम क्या होती है. जब भी हम मेडिकल ऑन्कोलॉजिस्ट को कहते हैं कीमोथेरेपी दे दें तो वो एक चीज़ पूछते हैं हमसे. ठीक है, तो क्रेटिन बहुत इंपॉर्टेंट है. रीनल डिस्फंक्शन के अंदर आप सिस्प्लैटिन नहीं दे सकते. ठीक, उसके अलावा क्या टॉक्सिसिटी होती है इसकी. डॉक्टर नाजिश, सिस्प्लैटिन की क्या कॉम्प्लिकेशंस होती हैं, क्या टॉक्सिसिटीज होती हैं.
सर रीनल फेलियर और डिरेंज्ड लिवर फंक्शंस
और दो कॉमन इसकी प्रॉब्लम्स हैं. डॉक्टर जफर, न्यूरोटॉक्सिटी होती है, पेरिफेरल न्यूरोपैथी होती है और ऑटोटॉक्सिटी होती है. ठीक है, तो जब ऑन्कोलॉजिस्ट कंसीडर करते हैं सिस्प्लैटिन को तो उससे पहले वो इंश्योर करते हैं कि मतलब ऑलरेडी डिटोरिएटेड ऑडिटरी फंक्शन ना हो या ना उसकी प्रॉब्लम ना हो. ठीक है, तो इस ड्रग के बारे में थोड़ा पढ़ लें, ये इंपॉर्टेंट ड्रग है हमारे उसके. सही, आगे चलो.
There is a criteria for cisplatin in eligible patients. The performance status is 2 or more than 2, creatinine clearance less than 60 milligram per minute, grade 2 or above auditory loss and grade or neuropathy, and AHA class 3 heart failure. In these patients we cannot administer cisplatin.
सो ब्लैडर कैंसर के अंदर भले आप न्यू एडजुवेंट सेटिंग में हो या मेटास्टेटिक सेटिंग में हो, फर्स्ट लाइन ट्रीटमेंट जो है वो सिस्प्लैटिन बेस्ड कीमोथेरेपी. और जब वो नहीं मिल सकती तो फिर अल्टरनेट ऑप्शन है, लेकिन उनके रिजल्ट उतने अच्छे नहीं हैं जितने. ठीक.
In unfit patients, patients for cisplatin, we administer methotrexate, carboplatin, vinblastine, that is called MKV, and gemcarbo, carboplatin and gemcitabine regimes. Usually the 50% of patients at time of diagnosis are ineligible for cisplatin containing chemotherapy. In MKV, the response rate is 30%, at toxicity is 23%, and in carboplatin gemcitabine regime, the response rate is 42% and toxicity is decreased to 13.6%.
So here is the message that in bladder cancer, the chemotherapy that we have, it is toxic and it has its own problems, and its response rate is not very good. So there is space in this area to develop more chemotherapies or use more chemotherapies or develop other treatment options so that we can manage these patients better.
Now, non-platinum based chemotherapy, that is gemcitabine with paclitaxel. Non-platinum combination therapy is not standard. It cannot be compared with standard cisplatin chemotherapy in randomized controlled trials. It is not recommended for first-line treatment in cisplatin eligible patients. And there is single agent chemotherapy. There is very limited data for that. The response rate is 25% and short-lived, and median survival rate is 9 months. Immunotherapy with pembrolizumab. It is a PD-1 inhibitor. It is for cisplatin ineligible patients. Response rate is 29%. There is less toxicity, acceptable toxicity in this with pembrolizumab, and the survival rate is 15.9 months.
So again, this drug pembrolizumab, in which other cancer we use as urologist? In RCC it is used. And how does it act? What does it do? Dr. Nazish?
Sir, they are the immunoreceptors जिनके ऊपर जाके मतलब the immune checkpoints in which it acts, and hence.
Dr. Basga? Okay. Dr. Harris? How does pembrolizumab act?
Sir, these are checkpoint inhibitors. They basically inhibit.
Dr. Shaw?
These are these surface receptors
Yes.
for the different substances to enter the cell. So when these drugs act on these receptors, they basically block these inhibitors. So they won't be able to allow or release or sort of one-way pathway.
Dr. Babar? How does it kill the cancers? How does it affect the cancer cell?
So it's acts on T cells, I guess.
It has no direct effect on cancer cells. Right? How does it kill? Dr. Mazhar?
In which cells PD-1 cell receptors are present, these act basically to inhibit the competitor inhibitors जो होते हैं ना उनको ब्लॉक करते हैं इनडायरेक्टली जाके, और जो सेल की जो प्रोलिफरेशन होती है दैट इनहिबिट करते हैं बेसिकली. बट
So basically the cancer cell with the help of PD-1 inhibit the T cells, and these T cell has the ability to kill the cancer cells. So basically the cancer cell is causing immunosuppression with the help of this PD-1 receptor, and these drugs block this PD-1 receptor and remove the inhibition of T cells, thereby killing the cells. So they do not act directly, they actually potentiate the normal immune system, and then the normal immune system kill the cells. Okay, so beside bladder cancer, this drug is being used in the renal cancer. Is first line treatment of metastatic renal cancer nowadays, and in other in BCG refractory non-muscle invasive bladder cancer, this drug is also being used, right? So this drug is going to be more important in the future, so we must know about this drug. Okay.
Now comes the second line chemotherapy. The cisplatin based chemotherapy for previously sensitive patients and paclitaxel is given in second line chemotherapy. Gemcitabine, vinflunine, PD-1 and PD-L1 checkpoint inhibitors.
So metastatic bladder cancer is basically a disease which is managed by oncologist overall. But as a surgeon, we have two very important surgical issues to deal with when we see these patients with metastatic bladder cancer. One is upper tract obstruction, the other is hematuria. So as a urologist, this is the importance of metastatic bladder cancer for us. Okay. So how does upper tract obstruction occurs in metastatic bladder cancer? What could be the different mechanism that can cause upper tract obstruction? Dr. Mashkoor? Sam?
In cases of metastatic bladder cancer, the tumor which is in the bladder itself, it can involve the ureteric orifice,
Yes.
and can invade and can cause resultant hydronephrosis,
Okay, this
and
is
that
one.
cause obstruction.
What else? This is one way of obstructing the upper tract. Dr. Zoha?
And if it extend into the retoperitoneum, or if it extend into the lymph node can cause extra luminal obstruction of the ureter
Okay,
as well.
this is two. What else? Dr. Zoha? Dr. Naseem? How does upper tract obstruction occur in bladder cancer? Dr. Rafi? Okay, you can have ureteric growth. Right. What else? Any treatment for bladder cancer can cause ureteric strictures? TURBT can cause ureteric strictures, right? If you use electrical current at the ureteric orifice, you end up having a stricture in the distal ureter. What else? Can radiation cause ureteric strictures? Yes. So if a patient has been previously radiated, he may have ureteric stricture.
It could be a cause of upper tract obstruction.
In posterior urethra.
Yes.
Yes, that can also cause, if it is bladder
That
outlet
is not
obstruction.
primarily upper tract, no, but that
No,
is secondary.
radiation can directly cause stricture in the ureters.
Ureters.
Yes. BCG can cause small capacity bladder, thimble bladder, and that can cause upper tract obstruction. So previous treatment of bladder cancers can cause upper tract obstruction. Bladder cancer can itself cause upper tract obstruction. Muscle invasive disease, right? So there are multiple causes of upper tract obstruction, right? Sir?
It is directly invaded by tumor cells. The growth within the ureter, the mass effect of or compression, and it can be secondary to TURBT.
Just a word about TURBT. If you understand two modes of using your diathermy, one is the electrocutting, the other one is the coagulating mode. Then these two have got different kind of sine wave, and they have got different kind of energy dispersion. Now they both have got a different kind of effect afterwards. For instance, if you are resecting a bladder growth and you are coming closer to the interureteric ridge or the two ureters or two ureteric orifices, then if you change your mindset from coagulating to cutting, then it will not have this kind of effect. Because coagulating current will be a little bit superficial. It will cause the charring effect as well as a superficial sort of a bleb of coagulating, say, proteinaceous material which can block the orifice. But if you are using an electrocutting and the cutting current, it has got more depth and it will open up the orifice rather than close it. So this is something to understand, because whenever you want to have a larger growth resected, then it's basically an art doing with both the things, not simultaneously but at random between cutting and coagulating. So as a matter of rule, if you apply this thing, that whenever you come closer to the ureteric orifice, try to be more on the cutting side rather than on the coagulating side.
Previous radiation can cause upper tract obstruction and previous diversion.
Just a little bit about the platinum-based therapy. Now, platinum-based therapy is also a kind of therapy which is used as a photosensitizer. Now, that is something which was missed in your slide. Now, photosensitizer is a substance which is used in photodynamic therapy. Now, this is not in conjunction with this topic, which is muscle invasive bladder cancer, but it is for superficial bladder cancers. It is not something which is out of fashion now. It is something which will come up again and again, because we are having a lot of different kind of treatment strategies for superficial bladder cancer, one of which is photodynamic therapy.
The definitive treatment in upper tract obstruction in metastatic bladder cancer is often not possible, and diversion is the only solution. The treatment is considered to improve the performance status of the patient and improve the renal functions, to improve the expected survival rate, and to have a better treatment plan, get time to better treatment plan, and to improve the quality of life.
So what is the survival of bladder cancer patients? If a patient is diagnosed metastatic bladder cancer today, how much you can expect him to live? This was shown in previous slide, but a lot of you were not present. Dr. Mavish, what is the survival of metastatic bladder cancer?
3 to 4 years.
Oh, this is too much.
So 15 months.
Okay. 14 to 15 months.
14 to 15 months.
With treatment. So this is important to consider for here. Well, if you are treating the upper tract obstruction for a patient who is going to live for 14 months only, then you really have to compare the risk and benefit, which treatment you want to give, which you don't want to give, and what are the expectations of the patient with you. Right? So next.
And that is precisely the fact that if you add on to something which is like more morbid, then it will not be a good treatment strategy. Now, just to clarify my point, and which actually is stressed upon many a times, that whenever you see a patient and who is already in renal failure, and that renal failure is a stable renal failure, which means that after decompression of the upper tract, you are not able to reach up to the normal values, then that patient, if is pushed into a group of say urinary diversion through ileal conduit or ureterosigmoidostomy, then it will be increasing one morbidity, and that is renal failure. Now already you have said that the life expectancy or the survival benefit that you can give to this patient is like 14 months. If this 14 months is with morbidity and the person is having renal failure coming up early, then I think we have to rethink the whole subject again. So to start with, whenever you have a patient who is having a normal renal function with a bladder growth and a muscle invasive disease, and you are thinking about something called radical surgery and urinary diversion, just for a moment, please check the GFR, because that is one thing that is the determinant, and that will increase the kind of speed up the whole process of morbidity, and it will take away the patient. Now, once the patient has got only one thing to cater for, and that is cancer. Now you are putting in another thing in the equation, and that is renal failure. So two morbidities, competing morbidities, racing against life. It's too difficult, too much of a burden on a patient. So please think and advocate in terms of patients and for the patients.
So what are the treatment options for these patients, for upper tract diversion? What we commonly do, what can be done? What is the commonest method we use to decompress these kidneys? Right. Okay, first is peace. And why not DJ? Right, so with bladder growth, most of the time you cannot identify You cannot access the system retrogradely. That's why you have to put a PCN, and later you can place an anti-grade DJ stent. Right? DJ can go, but mostly it doesn't. So we don't try. What else? What else? Conduit, uterosigmoidostomy, right? Another simple thing, uterostomy, simple uterostomy. So these are the different methods by which you can manage, and there is no data regarding which method is better or which method is not better. There hasn't been any studies. So you have to analyze each patient independently, discuss with him what he wants, what could be the risk and benefit of all these things, because there is no perfect solution in all of these. None of this is a perfect solution for the patient. So you have to go individually with the patient, discuss, and then plan what you want to do.
Now suppose you have got a patient who is in renal failure already with muscle invasive disease. Out of these 1, 2, 3, 4, 5, out of these 5 options, what would you select for a patient with renal failure? Ureterostomy. So somebody can say that this is something which is like an old technique. It will have a lot of say complications. So how do you justify yourself? Yes, sure.
Dr. Lare.
Dr. Lare. How you justify yourself and your decision that ureterostomy is the best option in a patient with renal failure?
Sir, if the patient is in renal failure, if we are using any portion of the gut, it will increase the renal failure. And the second thing, percutaneous nephrostomy, the patient has to deal with 2 bags all the time. While with ureterostomy, there will be 1 bag only attached to the abdomen. That will be more good for the patients for physical activities as well.
Right. So out of these 5, which one is the one which is like continent and the others are incontinent diversions?
Sigmoidostomy is the
ureterosigmoidostomy. So if there is a continent diversion and the person is in renal failure, you are giving more time for the urine to be absorbed. Right? So one thing that is out of question is ureterosigmoidostomy completely. So any continent urinary diversion in a patient with renal failure is out of question, out of your choice of the spectrum of choice, right? The second thing is, out of, again, ek cheez to nikal gayi, the remaining 4, what would you select? The one that has got no connection of urine with an absorptive surface. The one that is left out is only one thing, and that is ureterostomy, cutaneous ureterostomy. Now, somebody can ask you another question. What is the most dreadful complication of cutaneous ureterostomy? How would you like to do it? Yes.
Complication of ureterostomy.
Stricture.
Stricture.
In the ureterostomy.
And? The better word for this thing is stenosis rather than stricture. Yes, your intention is correct that the orifice will close down on its own because it is flush with the skin. And when something is flush with the skin, then the skin is something which is actually growing. It is not something which is static. It has got its own rate of multiplication and shedding off. So the skin will actually close the orifice, and that is the cutaneous ureterostomy orifice. So that is known as stenosis rather than a stricture. The second thing is, there is a way to deal with this thing. There is a natural pit, and that natural pit is actually the umbilicus. So you put both the ureters through the umbilicus, and that is something which nature is giving you. So whenever you delve yourself into the practice of called reconstruction surgery, you must also think about the anatomy in a way that that an artist actually sees a picture. So you exploit something which is not abnormal, you exploit something which is normal. So normality is giving you some an advantage, and that is a natural pit, and that is something which is an umbilicus. So you can pull out both the ureters through the umbilicus, make a pout of it, just like interception of an intestine. You make both these ureters intercept on your own, and then it will be just like a pout over the skin, not flush with the skin, and it will not close down. So there is a technique for doing it.
So in practically what we see, mostly we keep this patient on percutaneous drainage. What are the problems with PCN?
Dislodge PCN.
Right? So the biggest problem is dislodgement. They keep on. So how can you avoid dislodgement of a PCN?
Better counseling the patient to take care of that nephrostomy, and double time stitching of that nephrostomy tube.
Proper dressing. Are there any other types of nephrostomy tubes which are available, which retain better?
Like Malicords.
Malicort. What else? Can you use a Foley catheter as a nephrostomy?
Yes.
With a balloon. What else? Okay.
Just a question to confuse the candidate. Now, which of the catheters has got a pigtail and which of the catheters has got a rat tail? Yes. Ji, Shwasa. Now, Malicort has got a kind of a rat tail. If you have got that kind of a Malicort. Malicorts are two kind of Malicorts. So the rest are a pigtail. For instance, this PCN which you use is a pigtail.
Okay. So these are the different nephrostomy tubes.
The difference between these two tails, pigtails, we have seen a lot. They're just a tube and tapering at their insertion. This Malicort has got like a fan-like. So Malicort is retaining, self-retaining.
Yes.
So why you are calling it Malicort and why you are calling it pigtail?
No, pigtails are different.
Pig means pig. Why does this name?
You see, the pigtail is actually for self-retaining purpose. The same goes with the Malicort. These were the catheters when there was nothing called a self-retaining catheter in terms of a double channel through which one channel is for the balloon to be filled, so that the balloon with inflated material inside can retain the catheter. Now, those were the days when we have got these kind of catheters. For instance, Malicort has got something which can be collapsed under pressure when you pull the catheter out, but if you don't pull it out, it will retain the thing within the cavity in which you are placing it. For instance, if there is a rat tail attached to the Malicort, then the tail will actually cross the PUJ, coming like this one, coming into the ureter, and this was used when, for instance, you have done anastomosis and in order to protect the anastomosis. So this is a kind of a replacement for JJ stent. So these were the catheters which were used when JJ stent was not on the scene. When JJ comes in, these catheters were actually out of practice. Still we can use these catheters. For instance, a single catheter, the Malicort catheter without, that is known as the D pizza catheter rather than a Malicort catheter, which is the same except the tail. So if you put this tail out, it becomes a D pizza catheter, and that can be used for retaining a catheter suprapubically into the bladder. So these are the catheters which were used. This one.
Simple.
This one. You see? So for instance, if you pull it out, the hinges which you can see here, all the brackets, they become collapsed and it becomes like a straight line and you can pull this thing out. So these were of historical value, but they can again be used whenever you don't have, for instance, this kind of a thing. So you can use this. It's the same. It has got historical value, but you see, country like us, where we don't have a lot of things manufactured in our country, we might be able, for instance, if there is no availability of this catheter. Now these catheters are always available within the country. They can be used. So the purpose should be clear in our minds, and then we can use anything. The purpose is to drain without any tension, decompress the system.
So in our practice at SIUT, we mostly manage these patients with PCN, and the biggest problem we face is dislodgement. So maybe we can rethink our strategy of using different catheters so that these patients can benefit from this.
You see, there is a string attached to it. Can anybody tell me why this string is attached? And whenever you place for instance, a PCN tube or a DJ, this string is actually cut off by our technician, and nobody asks him why you are cutting it off.
The purpose of this string is then whenever we place the stand, we have to stretch the string and then tie it on the valve which is present outside. So basically it curves the end of the tube and it becomes a retained tube, unable to dislodge on its own. And you are very much right that we usually cut this tube, except in the transplant patient we have seen that they do place and use it properly. And same applies whenever we are removing the nephrostomy tube. We have to cut the string first and then we can remove it.
See. These are different catheters. Next. So the next biggest problem for this patient is hematuria that we have to deal with, right? So what can cause hematuria? Why hematuria occurs with these patients? Hematuria can occur anywhere from the urinary tract. For bladder cancers, why hematuria occurs? Because of infection can precipitate hematuria. What else? The vessels are very thin. They are new vascularization, tumor vessels. So with any straining or with a catheter you might have placed or with infection, they can start to bleed. Right. Next. So these are the different mechanisms by which this hematuria actually occurs. Next. Now the big question: how you manage them? Salim, batao.
Management is conservative and the bladder. It is managed conservatively with the bladder wash, bladder irrigation with the 3-way catheter. We will check the coagulation profile, and we can also administer the transamine.
This transamine, I don't know what is the role of this transamine. Sir, what is your experience about? Sometimes we use it, sometimes we don't.
Actually, the kind of practice we are in, we don't believe in the action of transamine. But again, whenever somebody is in a situation in which everything is failing, then the last resort is just use transamine and cross our fingers. That's the only thing. But if you ask, for instance, a colleague from nephrology, a senior colleague, for many a times I have asked myself to pose this question to Dr. Ijaz Saab and Dr. Fazal Saab. They both think that transamine has got no value, at least in our practice of patients with renal failure, having hematuria, or patients with cancer or bladder tumors or whatever, having hematuria. So in urology and nephrology, I think role of transamine is anecdotal.
So it's only a desperate effort.
So that is anecdote.
In gynae, yes, they use it. In gynae, they use a lot of transamine.
You see, whenever there is hematuria and intractable hematuria, when you are doing TURP and you use transamine, it will give you a false relief that there is no bleeding. Now the bleeding vessel is actually there. You are only addressing something called coagulation, a balance between procoagulant and anticoagulant. That's the only thing.
We can use the irritant irrigants like 1% silver nitrate and 1 to 2% of alum and 4% of formalin. And the invasive management for hematuria is cystofulguration, selective angioembolization, ligation of iliac arteries, and palliative cystectomy. That is the last resort and very invasive procedure.
If you face with the problem of doing cystofulgration in a patient who is bleeding, what we often do is that we try to fulgurate the visible part of the bladder, which is not really the answer. Sometime, but most of the time, you have to resect the growth, go to the base of the growth, and then coagulate that vessel to secure bleeding. Otherwise, it doesn't help. Only fulguration will not help in most of this.
No, in January 2021, there will be an article in Journal of Urology, and it actually addresses this problem and this sign, and that is hematuria. And the whole topic will be classification and staging of hematuria. So it's a staged hematuria, and I posted one picture on Infogram concerning this topic. So now from maybe next year onwards, when it will be a part of the natural text of urology, then you will have, whenever you say that a person has got hematuria, then you must tell us what's the stage 1, 2, 3, 4, 5. There are 5 stages of hematuria.
The other issues of surgical importance are catheterization, urinary fistula, and urethral strictures.
There are other less important issues. These are issues also faced by us as surgeons.
Achha, why it should not be done? चलें यूँ पूछ लेते हैं. बोलिए कोई और बोल रहा था.
Dr. Maria.
Sir, it can upstage the tumor.
How?
Sir, if the tumor is in the bladder, and it can upstage, मतलब उसकी encroachment हो सकती है towards the skin. T4 stage में convert हो सकती है.
Suppose there is a bladder growth which is actually at the bladder neck or the outlet of the bladder mouth, and it is causing obstruction to the passage of urine. And there is nothing on an ultrasound which can give you an impression that there is any other site, probably on the anterior wall, which hasn't got any bladder growth coming out. So in that instance, what are the options? How would you relieve that patient of something called retention? And that will happen in the middle of the night.
If there is no documentary evidence on ultrasound, we can go for...
There is a documentary evidence. I am giving you the documentary evidence that the growth is at the bladder neck. And the bladder wall, particularly the anterior bladder wall, is without any evidence. There is no growth.
Sir, not putting a suprapubic catheter in bladder growth is not an absolute contraindication.
So that's the point. You see, that is not a absolute contraindication. Now the person is in retention. The person is not having urination for the past say 12 hours or 24 hours, and he is in distress. So you cannot just say that since there is a chance of having whatever you say of increasing the morbidity, maybe changing the stage of the disease, I cannot put in the catheter. You have to provide some relief to the patient. So how would you provide the relief? That is, you are not actually going over the rule, but you are providing relief to the patient. So whatever you do in life, it's with good intention. If the intention is correct and the intention is to relieve pain, intention is to have another channel for urine to come out, then you are justified. Even to the extent that if you increase the stage of the disease, you are justified. Sometimes we have got experiences when the bladder is full of clots, the person is not able to pass urine, the person is not in renal failure. For that matter, you have to do something called, just like an incision for cystolithotomy, you open up the bladder and evacuate the clots by an open technique. You are justified. You are not doing something for your own benefit. It's for the benefit of the patient. If you remove the clots, the patient will be relieved and you can think of other things later.
There is a role of radiation in hematuria. It can control the local symptoms of hematuria and pain, and it can also be given to metastatic sites like bones and cord compression, which causes cord compression.
So what is the take-home message? Dr. Najam. can you summarize what we learned? Dr. Nazish.
Sir, by carefully plan for your patient, that keeping in mind the life expectancy of the patient, so give him the available options, let him to decide, and better counseling of the patient, and properly planned for the management of the patient is most important thing.
So bladder cancer cannot be managed with one treatment that fit all. So you have to see an individual patient condition. And as a surgeon, you must take care of the upper tract obstruction and hematuria. If you deal with these two, because these are the two problems that impair the quality of life of these patients. So if you manage these problems properly, these patients are going to live a better life, whatever they have short lifespan. Right?
Just to add one more point, whenever you address this problem or issue of counseling a patient, and you want to have something coming out of the mouth of the patient, whether he or she wants to have this treatment or that treatment, first of all, you have to convince yourself what is more appropriate for a patient in a given situation. Now, these are called custom-made sort of decisions. You have to have sort of a decision for a particular patient which might not be the same as for another patient. So you must actually treat each patient as an individual and first convince yourself what is the best treatment, and then ask the patient that these are the options. Now, out of these options, in my opinion, this is the best treatment, and let the patient decide whether he or she wants to be with your decision or not. But asking the patient, बताएं जी क्या करें, आपको मसाना निकाल दें या रहने दें? So how would he say that मसाना निकाल दें? First, you convince yourself whether you are able to do it properly. Second thing is whether you are able to do it with something called urinary diversion that will affect the life of the patient less as compared to what he actually is in. The second thing is how many days and weeks and months would you like this patient to be with this kind of a situation? Maybe 2 years, maybe 3 years, maybe without any harm and perfectly healthy life for God knows how many years. So you have to be very clear statistically as well as scientifically in your mind first. So try to read the subject as the subject is at a given time. Maybe when somebody has read it 10 years back, it was something else. Now it is different. Now the evidences are different, the treatments are different. Maybe there is one thing which we have discussed, and that is cutaneous ureterostomy. Somebody can say to you, this was a treatment 30 years back. This is a treatment, yes, 30 years back, but this is a treatment which is now a reality. And if you read the literature, this was a subject which was addressed very recently again. They have taken this subject on the podium now. Why? Because they have got a lot of patients with renal failure. They have to have answers for these patients. And this is our reality actually. We have got patients with renal failure.
Yes.
I have seen many cases where we have got cystectomy done and ileal conduit done, and the patient was starting from 1.5 creatinine, now ending up with 3 creatinine and 4 creatinine, and later the person is on dialysis. We are not actually doing justice. We have to think a lot.
Dr. Lari was saying.
Very little is known about ALM and enormous line irrigation. So what do you think, which thing is better for a patient of bladder growth specifically? The ALM or the enormous line?
LM wash or enormous line wash?
The person is in good shape without any renal failure. You can use alum, but alum is only not for irrigation purpose. It is a kind of a chemical which can stop the bleeding. So it can just stop the bleeding chemically. It might not be used for irrigation purpose alone. You can use RO water rather than saline just because of the reason that these cells are tumor cells and they can be lysed and they have to be lysed. But again, the problem is with any bleeding surface. The bleeding surface will absorb more of it. So if you use RO water, it will be absorbed into the circulation, and then you will have hemolysis within the system. So for that reason, saline is used. But if you are using it for rinsing purpose, for instance, you have done a very good cystectomy and you want to have lavage of intraperitoneal surface, then you should not use saline, you should use RO water. See, why? Because you want to have lysis of the cells which might be in the solution, in the secretion within the intraperitoneal cavity. So the purpose should be very clear. If this is a closed cavity, which is a bladder, which has got a growth and that is a bleeding surface, you must use saline rather than any other thing. But to stop the saline, or to stop the bleeding, yes, you can use a chemical that is alum, potash alum.
Any other question? Dr. Salam.
If I am in ER and patient come with urinary retention and ultrasound bladder is full of clots, and we try to pass Foley's but failed, and then we have option for SPC, or we can think about decompression of kidney just for sake of relieving by decompression for bilateral PCN.
In acute situation, the kidneys will not be dilated. How will you place a PCN? You have to do something with the bladder. You can do a cystoscopy and go in. But you cannot do PCN in the emergency.
Thank you.
Yes.
You can have a cystoscopic bladder wash, but again, if the bladder growth is so much that it is not allowing your catheter or your cystoscope sheath to go in, then you should know how to open up a bladder. At least it's just a small incision. You are right there into the bladder. There is nothing inside. Take out all the clots. Just do 3 stitches. Close it down. Suprapubic catheter or place कर दें.